Welcome to Health Watch, presented by Novant Health. I'm your host, June Baker. Our show features local physicians and health professionals discussing health topics of importance to local residents. Today, Dr. David Zub of Carolina's Pain Institute will join us to discuss radiofrequency ablation, a new type of treatment for pain at Brunswick Novant Medical Center. Then Stephanie McLeod and Ray Lindsay will join us to discuss a new process at the hospital known as nurse bedside reporting. Stay tuned to learn about valuable health topics with Health Watch. Our first guest is Dr. David Zub of Carolina's Pain Institute. Dr. Zub, welcome back to the show.
Thank you. My pleasure to be here.
Well, it's great to see you again. And for those of our viewers who have not met you, tell us a little bit about your practice.
Well, my name is David Zub. I am a board-certified anesthesiologist and pain physician, and I have a practice called Carolina's Pain Institute that is over by the old Brunswick Hospital. I've been there for 2 years now.
Wow.
And things are going very well. We're there 5 days a week. I did my training at Wake Forest University, Baptist Medical Center. I did my anesthesiology there for 4 years, and I did an additional pain fellowship year also at Wake Forest for an additional year, and graduated in 2010 now. It's been a couple of years. Goes by fast.
So you're board certified in anesthesia also?
I am. That's correct.
How long have you been practicing in Brunswick County? I think you said 2 years?
2 years, that's correct. I came straight from fellowship, opened that office here in Brunswick County immediately afterwards, and been here for 2 years now. Slowly growing, but it's been a great experience, and it's a great community to be a part of.
So how have you found Brunswick County to be?
It's a very welcoming place. I've had a great experience here. Both the medical community has been very welcoming and very inviting, as well as the greater community. And I've started trying to become more involved in the Brunswick Medical Society, and I've just recently joined that. And so it's been a positive experience all around.
Great. I bet your family loves living at the beach.
Oh yeah, we're having a good time.
Well, the main focus of our interview today is a procedure that I just heard about, and it's new, and it's coming to Brunswick Novant Medical Center, and it's called radiofrequency ablation. Is that correct?
That is correct, yes.
Well, let's just start with the basics. Okay. What is radiofrequency ablation?
It uses technology that essentially applies a little bit of electricity to a very small area of tissue, and essentially heats that tissue up, and it essentially self-cauterizes. So you can control the amount of electricity that goes to the area, you control the size of the lesion by controlling the electricity, and that allows you to cauterize tissues that may either be diseased or not functioning properly. And so that's the basic principle of the procedure. And you can apply it to many different pain syndromes, many different other musculoskeletal complaints as well. Okay,
now, where is this procedure done? In the operating room?
We do it currently we do it in the operating room. It can be done just in a regular procedure suite, but oftentimes folks need a little bit of sedation, just because it is a little intense at times when you first start the procedure. But most of the time we do it in the operating room.
And so you can do it on any part of the body that's experiencing pain?
Traditionally, the places we use it are in the neck, in the thoracic vertebrae, and in the lumbar vertebrae, along where there's musculoskeletal pain. We use it along small nerves that go into the joints between the vertebrae, called the medial branch nerves. Those nerves don't control any muscle movement, don't control any sensation down the legs. Right. All they do is control a sensation in the joints between the vertebrae. And so we're able to pinpoint those little nerves. Pain, that's correct. We're able to pinpoint those little nerves and then cauterize those little nerves.
So you cauterize the nerve.
Correct.
And that takes away the pain?
Essentially, you take away the sensation to that joint. And you have to remember that every single level of the vertebrae column has, every vertebrae has 2 joints. Each joint is innervated by at least 2 nerves, sometimes 3 nerves. And so you have to do multiple levels at a time to make sure you get the whole area. Other places you can do the procedure are also in the sacroiliac joint, which is a large joint in the pelvis that oftentimes get traumatized through childbirth or just physical trauma to the joint itself. And there are the same little sensory-only nerves that go into that joint that you can also do the same radiofrequency ablation for.
Really?
If you can show that the majority of the pain a person has experienced is coming from that joint.
Now, I guess it's like a little needle that goes in.
Correct.
It's very small and.
So what you do is you actually do a few what are called blocks to block that nerve. You do that several times before you do any radiofrequency ablation. That shows you that, okay, yeah, those are the nerves that are the ones causing pain.
Right.
And by blocking those nerves or taking away their sensation, you actually get pain relief. Whether it's a day, a week, or a month, everybody's a little different. After you do a series of 2 or 3 of those blocks, you can go back and then do the radiofrequency ablation. And the radiofrequency ablation, you actually cauterize the little nerves. Nerves grow back very slowly. Oftentimes they do grow back.
Oh, they could come back.
They could come back, but you're talking anywhere from months, 6 months to a year. If the nerve does grow back, oftentimes it doesn't cause as much pain as it previously did. Everybody's a little different in that respect. But it is a procedure that if they do grow back and you do have a recurrence of pain, it can be done again. It is not a one-time.
And the patient is awake when this is done. Correct.
Oftentimes we give a little bit of sedation. We use small needles to put right there where that nerve is, and then through that needle you put a little electrode that actually carries the radio frequency waves to the nerve itself. But we use small needles, and that's usually the most intense part, is just putting the numbing medicine in the skin. And the lidocaine, once that's there, it shouldn't be too bad.
How long does it take?
Usually about 15 to 20 minutes to do the actual procedure. Each little nerve, you actually do the radiofrequency ablation of each little nerve for about 90 seconds. So if you're doing, say, 5 lesions, 5 radiofrequency ablations, you multiply the 9 times 5.
Oh.
And that gives you a general idea how long it'll take.
Well, I know our viewers will be interested. I know there's a lot of folks in the area suffering from pain. Let's talk about the safety of this procedure.
Sure. Of course, anytime you go through the skin, there's always a risk of infection and the risk of bleeding. If you are not immune compromised, the risk of infection is very low. Even for folks who are on blood thinners, this procedure has a very low risk of any continued bleeding once the needles are taken out. Those are the 2 big main concerns you have anytime you do this procedure. Occasionally, folks will have what's called a neuritis, or the nerve itself, before it completely degenerates, gets really inflamed for a short while. And so to keep that to a minimum, what we do is put a little bit of anti-inflammatory right there where that nerve was just lesioned.
Other than that, are there any other side effects that a patient might experience right after the procedure?
Oftentimes, for the next 24 to 48 hours, they're sore just from the needles themselves and have to put ice on the back. But side effects such as dancing and spontaneous walking aren't too bad.
So the patient can return to normal activity right after the procedure?
Correct. I usually tell folks just to take it easy.
Sure.
Don't do too much that same day, but the next day, back to work, back to whatever your normal activities are.
And is there any special preparation that a patient has to go through in order to have that procedure?
No, it doesn't require any anesthesia or preoperative evaluation.
Okay.
As long as you're otherwise normal, don't have an active infection going on, most people are good candidates.
And the recovery time is, as you said, just a day or so?
Minimal.
Just minimal.
That's correct.
Is that a procedure that most insurance companies would cover?
Most do. Like I said, what you have to do first is show that you have found the area that's painful, block that area with a set of either 2 or 3 blocks,
and
injections.
that would be done in your office?
That is also done at the hospital. The blocks are done at the hospital
I see.
and the procedure suite. In each insurance varies by how many are required. And so that varies from insurer to insurer. But once you satisfy those requirements, say, yes, this is the painful area, you blocked it, they've got relief, you can go on and do the radiofrequency ablation.
But not at the same time. This would be
Not
a
at the
later
same
date.
time. Yep, that's correct.
Oh, I see. Well, that's really good information, especially for those folks who are suffering from long-term chronic pain out there. And I know you offer many other types of treatment for pain. Let's talk a little bit about those other types.
Okay. I also do medication management. Oftentimes, folks will go through physical therapy, which is a great modality. They'll go through other treatments, such as just watch and wait, non-steroidal anti-inflammatories, and sometimes this just don't cut it. And folks need a little bit more relief using other medications we have at our disposal, whether it be antidepressants, muscle relaxants, opiates themselves, and anticonvulsants and other medications that we have at our disposal. In the office, I can do epidural steroid injections for folks who have radiating type pain down the legs that comes from either a disc problem or what's commonly called sciatica. Oftentimes, just a simple epidural steroid injection in the office will help with that.
It's an injection of steroids and
That's correct.
anything else that...
Just a little bit of normal saline. And that calms down inflammation around the nerves that are irritated from either the disc or entities such as spinal stenosis. We can also, for things such as postherpetic neuralgia, you can use different types of medications. You can use topical topical lidocaine. There's also some topical patches to actually burn those nerves, quote unquote, with a very strong capsaicin preparation that is fairly new over the past couple of years. So that's the majority of what I do in the office. Over at the hospital, for the procedures, we can also do epidural steroid injections, a variety of different what are called sympathetic blocks for things such as complex regional pain syndrome of the upper or lower extremities, for chronic abdominal and pelvic pain as well. Sometimes a sympathetic block is needed to help stop the transmission of the pain down the sympathetic nervous system.
I heard something about implanting some sort of a stimulator, a pain. Can you talk about that a little bit?
For folks who have had, for example, back surgery that may have worked for a short while and the pain returns,
yes,
or folks who have had multiple surgeries and for some reason, whatever reason, they just can't get any pain relief, a spinal cord stimulator essentially is an implantable device. It's a very small wire that goes along the spinal cord, and it changes the sensation that they get in that extremity. It essentially overrides the normal pain sensation and the normal pain fibers and provides a different sensation. Now, I've never obviously had one myself, but people tell me it feels like electric massage inside the body. It's different from a TENS machine because a TENS machine will stimulate the muscles, but a spinal cord stimulator actually directly stimulates the spinal cord and the nerves that run along the spinal cord. Another good patient category for spinal cord stimulators is folks who have very intractable diabetic peripheral neuropathy.
Oh, I see.
And that's getting more and more common with our country becoming more obese, people are getting more diabetes, peripheral neuropathy is becoming more common. And so all that burning pain down the legs and the feet can often be treated and overridden by the spinal cord stimulator. It's a good treatment modality for that as well.
Would something like that be done in the hospital? So
we do the trial for the spinal cord stimulator at the hospital. It doesn't require any overnight stay. The trial is just a daytime procedure, and you go home with the trial. That same day. It's very promising and very good technology for the right patient.
Getting back to the ablation for a second, I know that, as we said, it's going to be a new procedure at Brunswick Novant Medical Center, but I know that you've done many before. Is that correct?
Correct. At my fellowship training at Wake Forest, it was very common to do several patients a day for do radiofrequency ablation on.
Well, if we have patients out there who would love to come see you because they suffer from chronic pain or what have you, how would they best do that? And do they need a referral?
It is best to have a referral. It's best to have a primary care doctor or another physician who's looking after your chronic health problems to make the referral. And all they would need to do is call our office number, which is 910-754-8940. or have the primary care doctor fax over a referral at any time. I'll be happy to take a look.
That's wonderful. Well, thank you so much for coming back today to talk with us. It's great information, and I look forward to hearing back from you as to how this all turns out with the ablations.
Thanks, June. Appreciate it.
All right. Our next guests are Stephanie McLeod and Ray Lindsay of Brunswick Novant Medical Center. Well, welcome, Stephanie and Ray. I'm so happy to have you guys on the show today.
Thank you.
I want to get started by learning a little bit more about both of you. Let's start with you, Stephanie. How long have you been at the hospital, and what is your role there?
I've been with Brunswick Novant for about 4 years now, and I'm the Chief Nursing Officer. And what that means is I oversee all of nursing, all of their activities and their day-to-day operations.
And could you share a little bit about your background, how you got to be where you are today?
Sure. I worked at a hospital before coming to Brunswick in South Carolina for about 25 years, and most of that time was in some type of administration, and a lot of it, of course, with nursing administration. And then I moved to the beach. I have family here, and went to work for Brunswick Novant, which I researched fully because I wanted to make sure that I was going to a top quality hospital, and I found that their mission, vision, and values were very close to what I believed in and what it meant to take excellent care of patients. So here I am today, and I'm very happy.
Wow, well, it sounds like you bring a great deal of experience to Brunswick Novant Medical Center. And now, Ray, I would like to talk to you a little bit about the same things. How long have you been at the hospital?
I've currently been with Novant since about 4 years as well.
4 years?
Yes.
And what is your role there?
I'm currently the nursing manager for the medical surgical unit that we have. That's the inpatient 50-bed unit at the hospital, and I work daily with patients and families, and with the nursing staff as well as administrative role.
Well, what is your background? How did you get where you are today?
Well, I've been a nurse for 22 years.
Really?
Both in geriatrics, dealt with geriatrics, critical care as well, and administrative duties as well through that. Probably been in administration for about eight years within that 22 years.
When you say the medical surgical unit, that's the unit where some folks could just be sick, or some folks may have had surgery also, and
That's
they're
right.
together on that unit?
Right.
So it's sort of...
It's inpatient services that we have at the hospital, and both medical folks can have long-term care medical problems, acute medical problems that come and need nursing care, hospitalization, whether it's through antibiotics or to take care of pneumonia, that type of thing. And also surgical. We deal with both orthopedic or bone-type surgeries. We have the orthopedic surgeons there, and then we deal as well with abdominal surgeries.
Well, good. Well, I've asked you here today to discuss a new topic that I just heard about. It's called bedside nurse reporting, I believe. Is that the correct title?
Nurse bedside reporting.
Nurse bedside reporting. Well, tell me what that is.
Well, typically in hospitals, and some hospitals still do this, when nurses are at change of shift, when one nurse is going off and another nurse is coming on, they give a report to each other on all of their patients.
Right.
And as I said, the old model was for the nurses to meet at the desk or in a room and discuss each patient and, about what their what was wrong with the patient, what their care should be, what goals the patient should have, and an overall history of each patient. So they were reporting off to each other.
And they did that at the nurses' station.
Generally speaking, or either in a
office.
room that was designated as a report room. We have chosen a new methodology, and we feel like it is what is best for our patients and their families, and we call it nurse bedside reporting. And this is where the nurses, one going off and one coming on, meet inside of the patient's room, meet with the patient, engage the patient in the report off, and also the families, and they talk about, they give a report to each other right there at the bedside so that the patient and families can be a part of this. Of course, we ask the patient before we start, would they like to be part of the report? And if they say yes, then of course we do include them. We also ask any family members that might be in the room, is it okay for us to give a report in front of your family members as a confidentiality issue? And then they proceed in each of their assignment of rooms to give nurse bedside reporting at the bedside.
Now, and when do these conversations occur?
They occur at the change of shift. You have an off-going group of nurses, and then you have an oncoming group of nurses. So it's the continuing of care.
The overlap.
So it's just like Stephanie said. They talk about what's actually going on with the patients.
Well, why would the family be included? What would be the benefit of including the family in this conversation?
That we initially, when a patient's admitted to the hospital, the nurse will do what we call an initial nursing assessment, or an assessment, and that includes the background. A lot of times, patients they'll either forget things or they won't be able to discuss things with us. So it's very important for family members or significant others to be a part of that history as well. So based on medications, what kind of medications previously that the patient had, which is a huge safety issue on the part of the patient. And to utilize the family in that process, but also to discuss with the family and with the patient as to what's going on with the patient and what the goals.
So there's other topics that could be discussed during this conversation. Is that correct?
Absolutely.
I mean, and the way they are at home and things like that?
And we also feel like that it is part of the care process to include the family, because the significant caretaker may be a person that's included in the nurse bedside reporting, so they would have a better idea of what is going on a day-to-day basis, and then be able to know how to take care of the patient when they go home. So a lot of discharge teaching can take place with family members. As Ray said, filling in gaps with the history. Some family members may be too sick to give you a complete history, or maybe just poor historians. So therefore, we depend on family members to be included for those reasons as well. But overall, we feel like the family is a part of the healing process for the patients as well. So including them from day one is very important for the patient.
It helps engage a comfort level as well with patients. I don't know if folks, whenever they're in the hospital and they may feel sort of isolated, what's exactly going on, or what kind of goals do I have, or what do the physicians have in store for me. So this actually brings that more in focus.
Then it gives the patient the opportunity, or the family then, to ask questions of the nurses at that point?
Absolutely.
Okay. What do you do if there are visitors in the room?
Well, if there's visitors, obviously there's a privacy issue, and it's all based on what the patient wants. So it would be, we would ask the patient if they want to be a part of it, or if not, we'll have them excused for that particular time frame in order to carry on what we need to do at the bedside. And as well, if indeed the families or the patient wants us to contact someone, the nurses can actually contact someone by phone in the room as well and have them a part of the conversation.
Oh, really?
Absolutely. It's all up to what the patient wants and what they sort of the care that they want to receive as well, and who they want to be who they want to be a part of their care.
Wow, I think that's awesome. I didn't realize you could do it by phone, because oftentimes folks can't travel or have no transportation to get in. So I think that's a really important piece of it.
And our overall goal, June, is for the patient to truly understand why they're there. So we use 3 words. We call it Ask Me 3, which is what, why.
Why.
What, why. And we try to include that in the nurse bedside reporting so that the patient understands, what they're there for, what he needs or she needs to do about it, and why. What is the why behind, what's happening to me in the hospital? Why should I do this? What should I do to prevent coming back to the hospital? So those 3 words we try to introduce as well in nurse bedside reporting, so the patient and the family have a good understanding of why the patient's in the hospital, what for, and what they need to do about it, and the whys of their condition.
It sounds like to me this is a wonderful way to improve the patient's experience while they're in the hospital. It also sounds like a very safety-oriented procedure too. It sounds like you increase the safety of the patients while they're there. Have you received good feedback from this initiative?
We do. We both from families, from patients as well, being a part of it. But the nurse bedside reporting also stems as a part of hourly rounding, that we have part of that as well and you mentioned safety with patients.
Oh, so that hourly rounding, tell me more about that. I'm not clear on that.
Well, with hourly rounding, that's where a healthcare professional, whether it's a nurse or CNA, goes into the rooms on an hourly basis, check on the patients to see what kind of needs they have, whether it's their possessions being close by, call bells being close by, whether they have any kind of potty needs, going to the bathroom, or whether or not they need to reposition, change their positions.
So even though they don't call, you just show up in the room just to check on them and make sure they're comfortable and they have everything they need. And well, I would think that would cut down on the call bells, as you say.
We have found that it has decreased the patient actually putting on their call bells because someone's in the room at least once every hour. As Ray said, whether it's the nurse or the CNA.
And what's a CNA?
That's a certified nursing assistant.
Okay.
And they help the nurse. They're part of the team, very important part of the team. And so in addition, we have seen that it has decreased falls because someone is in there constantly. Well, not constantly, but at least for a period of time, every hour. At least, for 24 hours a day. This is practiced both on days and nights.
So it happens every hour
24
through
hours
the
a
night?
day.
Oh, wow.
Yes. Now, we don't, of course, wake a sleeping patient up, but we do, make sure that they're being monitored the same level of care that we give the patients on days.
Absolutely.
That sounds like a wonderful program, and I would think that it's been very well received.
It has.
Oh, it has.
Very
it
much.
Has, very much so. And we're very proud to have nurse bedside reporting and hourly rounding. And you'll find that that's prevalent across
That's pretty
Novant
standard?
organization-wide. Yes,
Yeah.
every hospital
That's great.
that Novant owns practices.
That's great. That's great. Well, before we wrap up, is there anything else that you can think of that we should tell our viewers out there other than we deliver a remarkable patient experience?
Just that, June. We're very proud of our new hospital.
Very much. Beautiful.
We want every patient to know that when they do come in as the patient, we will strive 100% of the time to deliver that remarkable patient experience.
Well, thank you both so much for being
Thank you,
here
Judy.
today. It's been a pleasure. I've learned a lot, and I think that you guys do a wonderful job there.
Thank you.
Thank you, June.
Thank you for having us.
You're welcome.
Absolutely.
Thank you for tuning in to ATMC TV's Health Watch. I hope this information was beneficial for you and your family. If you have any questions or topics that you'd like to see discussed on a future show, please email them to atmctv@atmc.coop. I'd also like to encourage you to visit Brunswick Novant Medical Center's website at brunswicknovant.org for more information on the hospital, local doctors, and a comprehensive health library. Thank you again for joining us today. Be sure to join us next time for Health Watch on ATMC TV.
This is ATMC TV Channel 3. We bring you the best of Brunswick.